Next is our expert on feeding and nutrition. Dr. Ajay Kaul is the director of the Neurogastroenterology and Motility Disorders Program at the Cincinnati Children's Hospital Medical Center. Welcome, Dr. Kaul.
Thank you. I am the only gastroenterologist in the team today, and as you can see, I'm going to go solo. So really, this has been a huge learning process for me. The past two days, I've learned so much about congenital myotonic dystrophy. I mean, I was focusing more on the nutrition part of it, but it was really good to learn from the pulmonologists, the orthopedic surgeons, the neurologists about, kind of completes my own learning process. And the other side of the story is learning from you guys that I've talked to a lot of the parents, and I've learned so much about what it is like, nutritionally and all the issues with G-tubes and J-tubes. So I thought I'd talk about that a little bit. In no way can I completely cover everything, but I'm going to give you in a nutshell, and then we could have an open discussion and have questions and answers both for me and for you. So it'll be mutual learning process here. So one of the major issues that a lot of our kids and adults with congenital myotonic dystrophies are the chewing process. So as you know, the muscular dystrophies involve all of the skeletal muscles of the body. This is skeletal muscle that's outside of your body and you have voluntary control over it. There are two other kinds of muscles in the body. What are those? Smooth muscle and the cardiac muscle. So you've heard a lot about cardiac involvement in CMD as well, and all the evaluations they do and the echoes and all of that. The third muscle, which I like to call the forgotten muscle, is the smooth muscle. And where do you find smooth muscle? In my part of the body, the gastrointestinal tract. The skeletal muscle really ends in the beginning of the esophagus, the swallowing tube. The rest of the swallowing tube and all the way down to the rectum is all smooth muscle. Not only that, smooth muscle is also present where else in the body? Gallbladder, urinary bladder, the ureters, the tubes that take urine from the kidneys down to the bladder, all that is smooth muscle as well. In addition, smooth muscles are also around blood vessels. So around, not the cardiac, but the aorta and the rest of the blood vessels, you have smooth muscle. So why is it that these muscular dystrophies, primarily seem to affect skeletal muscle and in some of the cases, cardiac muscle? Nobody really talks about the smooth muscle. Is it involved? Is it not involved? There really isn't a whole lot of literature out there or publications or studies or research about whether or not smooth muscle is involved in congenital muscular dystrophies. I mean, if you do a literature search, you're really not going to find much there. So that's one of the reasons, I guess, why I got involved is to kind of, I like challenges, and this is the population, like any chronic illness. Physicians don't like to take care of chronic illnesses because there's no cure. They're like, we don't have a cure for this, and they like to do things that they can fix and move on. Well, there's something to be said about making the quality of life of children with chronic illnesses better. I'm talking generally about all special needs kids, not specifically CMD. So the first thing, the swallowing, I was talking about the skeletal muscle. As you can see over here in this picture, when you first swallow, there's an oral phase followed by the pharyngeal phase. The blue here is showing you the food bolus, whether it's water or food, whatever you take in your mouth. What is the first thing you do? You chew it. And in that process, you have to have all of the muscles, your facial muscles, strong enough to be able to chew it well. You should have a strong muscle movement where it can manipulate the bolus in the mouth. And then when the chewing process is over, push it towards the back of the mouth, which is the pharynx. The pharynx then takes over the process of squeezing really hard to push the food bolus down into the esophagus. You see right there? That's the opening into the esophagus. Now, several things can go wrong in myotonic dystrophies. So you can't chew, you can't masticate as well. Also, the pharynx is weak. The back of your throat is weak because that's all skeletal muscle. So it cannot squeeze hard enough to push the food bolus down into the esophagus. Thirdly, this is the airway. This is the larynx or the windpipe. And this shuts down. You see this epiglottis? It shuts down as the food bolus is going down because you don't want food going into your airways as you're swallowing. And that's a protective mechanism. Guess what? All of this movement of the larynx is controlled by skeletal muscles. So if that's affected, you obviously will get aspiration, and that's one of the things we try to avoid. So then there's the pharyngeal phase, and the pharynx is squeezing here to push the food bolus down into the esophagus. And then here, the food has reached into the esophagus, after which the esophagus has peristalsis or serial contractions or milks the bolus down into the stomach. So that's how the food bolus reaches the stomach. So like I was telling you about, all the muscles on your facial muscles are all skeletal muscles, and they aid in mastication. So those, if they're involved, depending on the degree of involvement, the process of mastication may be mildly to severely affected, and you can't really chew. Also, one of the consequences of a poor facial muscle tone is poor development of your jaw, because the jaw and the occlusion is all dependent upon the pull and the tone of your facial muscles. When you don't have good, strong facial muscles, your jaw does not develop, and a lot of our kids will have what we call an open bite and malocclusion. So here's a picture of the airway. This is, the esophagus is right there, as you can tell. They're right next to each other. The swallowing tube esophagus is at the back, and this wide open thing here is the airway. You do not want food going down here when you're swallowing. When you're breathing, yes, that should be open. So you see the vocal cords, when you swallow, these vocal cords, they shut down. The epiglottis comes back down and shuts off the opening into the airway. This is what I was referring to. These are all of the muscles. This is a lateral view. Now you're looking at the neck from the side. This is the tube, the trachea, and these are all the muscles that help shut the airway as you're swallowing. And again, these are all skeletal muscles which are affected in dystrophy and can give rise to, depending on how severe the involvement is, can give rise to aspiration. So whenever there's a nutritional issue or feeding disorder, we have an interdisciplinary feeding team, which is part of the bigger dystrophy team at our center. And I was part of this, and essentially we offer family-centered care, which you've heard about, where we make shared decisions. There's the MD or nurse practitioner, the nurses, the registered dietitian, the therapist, speech therapist, occupation physical, home care, very important. We'll talk about nutrition, G-tube, and all of those stuff later. And of course, a social worker to kind of help them navigate the system. If there is a problem with feeding or the child's not gaining weight appropriately, any member of the team can identify that problem with the swallowing, feeding, and nutrition, any of them, including the social worker. Oftentimes, we've had referrals from social workers saying, hey, so-and-so, the kid was doing really well, but now he seems like he's having some problems. You haven't seen him in 6 months. Can you evaluate him? And then brings them back into the fold. When you have problems with oral or pharyngeal swallowing and biting, these are some of the symptoms that you should be looking for: coughing or choking with swallowing, which is indicative of aspiration potentially, difficulty initiating swallow, food sticking in the throat, drooling of saliva, unexplained weight loss because you're not eating enough, change in dietary habits, you start eating preferring certain kinds of foods that you know your body is telling you, yes, that's safe, that you can eat. You start avoiding some, like you avoid water, it's easier to aspirate. Recurrent pneumonias, if the kid's getting 3, 4 pneumonias, don't keep thinking it's because of poor clearance, don't blame the pulmonologist all the time, it could be aspiration. Change in voice or speech, again, because of the muscle involvement and of the airways, there's a nasal twang, and that kind of indicates hypotonia of the muscles. When the bolus goes down into the esophagus, and there's problems with esophageal motility, and that kind of stuff, you would typically have the sensation of food sticking in the chest, And sometimes you also get the food come back into the back of your mouth and out of your nose. And that's called regurgitation through the mouth or the pharynx. And then you can get the rest of those symptoms, including chest pain and odynophagia, which means difficulty or painful swallowing. So when you swallow it, it's very painful. You kind of have feel this pain in your chest. The rest are essentially the same as oropharyngeal dysphagia. Now, I just want to take a step back to kind of review what is malnutrition. A lot of times you are told, oh, your child is malnourished. What does that mean? So the World Health Organization, and that's what that stands for, not the music, the group, band. Malnutrition refers to deficiencies, excesses, or imbalances in a person's intake of energy and or nutrients. The term malnutrition covers two broad groups of conditions. One is undernutrition and the other is overnutrition. And we see both of these. We can see overnutrition and obesity as well as undernutrition in our population. Within the undernutrition group, you could have stunting, where you have low height for age, meaning if it's a 5-year-old, the child's really short, that's stunting. Wasting is low weight for height. So if the child is tall, but he's really skinny, that's wasting. Underweight is low weight for age. And then, of course, you can have all the different micronutrient deficiencies. When I say micronutrient, what does it mean? Vitamins and minerals. Now, you also heard this term, failure to thrive. Your child is failing to thrive as opposed to malnutrition. So failure to thrive is a significant interruption in the expected rate of growth. What is significant? Who decides what is significant weight loss? So you take help of anthropometric criteria. What are anthropometric? It's the weight, the height, the body mass index, and all of those to define. And there are 3 different definitions. If your weight is below the 3rd to the 5th percentile on the growth curve on more than one occasion, means it's persistent. Some people like to call that failure to thrive. The weight measurements that fall 2 major percentiles using the standard growth charts. If it falls, the growth is going okay, and then it drops 2 percentiles, that's failure to thrive. Others like to use serial Z-scores for weight for age or weight for height. And if it's less than 2 standard deviation, that's failure to thrive for them. Now, this is all a very kind of bookish knowledge. And if you really look in real life, I personally, I use these for sure, but that doesn't make me, this is not the only thing that determines that this kid needs, say, for example, a G-tube. That's not the only thing. You can use these parameters, but there are other things that come into play. You know, you've got to talk to the family, what the kids, the goals that they were talking about. You need to know what they are. So yes, these are good to have as definitions, but practically you may not necessarily use just these to make decisions. Other measurements that we've used in some of our kids is mid-upper arm circumference. So essentially, you measure the girth of the mid-upper arm. You could do tricep skin fold. There's a caliper that you use, and you pinch the back of your triceps, back of your upper arm, and you determine that serially to see if there's any loss of muscle mass. Then there's the MAMC, or mid-arm muscle circumference, which is calculated with this formula. Again, good to know, and sometimes good to follow a monitor and say, oh, well, his mid-arm circumference is going down, or the MAMC is dropping. So this is the only thing I've found in literature showing a growth curve of a boy with Mearson deficient congenital muscular dystrophy, and ignore this blue line here. So what this was trying to show was the child did well until about 3 years of age. Well, this died. So the kid did well at about 3 years of age, and then you can see those X's kind of flattening out and then actually falling more and more away from the growth chart. Now, that is a problem. I don't care 2 centiles or whatever, but the question that most people will ask is, would you at any point there, and where, would you have recommended a G-tube or supplemental feeding? And we'll talk about that. Some people would say, well, at the first impression where the kid had started to falter and straighten out or plateau, we should have put a G-tube. Others would say, no, I would have waited, and because he was still kind of trying to go and put all your, go ahead.
Is
Excuse me?
Is it likely because that's when the kid went to school?
It certainly is possible, absolutely. So don't just go by that. So you have to take into consideration other things too. So that underscores what I was trying to say. The blue line there is what we see in a lot of our kids where they're following their own centile. They're nowhere on the growth curve, but they are following their centiles. And a lot of the pediatricians will completely freak out and say, oh, your kid needs a G-tube, send them to the gastroenterologist for a G-tube. No, a lot of our kids fall under that, and they continue to do well, kind of maintain their own centiles, and that's perfectly normal. So just some facts about CMD. Energy expenditure is much lower in those who are non-ambulatory. That's not necessarily true just for CMD, but for other conditions as well, such as cerebral palsies, etc. Those children need less calories. However, having said that, there are some kids that I've seen with CMD that need significantly increased calories to grow. Not sure why, we could talk about that a little bit later. The weight loss that you see may not accurately reflect failure to thrive because the muscle atrophy may be caused by the underlying disease rather than poor nutrition. So the weight loss may not necessarily be because the patient's losing weight from poor nutrition. It may just be from muscle atrophy because of the condition of CMD. That makes sense? Then, like I said, the weight may track along below and parallel to the third percentile. That's fine. That's absolutely fine. Remember, the absorption capacity of the gut is normal. There's nothing wrong with the absorption of the gut, as far as I know. I haven't seen yet anybody that has malabsorption. So the gut malabsorption seems to be normal. Swallowing dysfunction may not parallel muscular degeneration. So if you're seeing that the general skeletal muscle is worsening, or the tone is worsening over time, it doesn't correlate well with the swallowing dysfunction. You may get worsening swallowing dysfunction even before the rest of the body the muscle starts to get worse. Go ahead.
Is there a better index to use rather than just weight to height ratio, like better than BMIs or fat test or something you should maybe push the pediatrician to follow? Or?
So the pediatricians can honestly have given this talk to the pediatricians and tried to tell them, but I think it's more from lack of knowledge and their fear of, we don't want to do anything. This is a very complicated kid. We don't want to, mess around with the nutrition and let the gastroenterologist take care of it, which is fine. And we kind of will just reassure the parents you're doing fine and the kid's doing okay. But what we typically like to see is if you can do a real weight, we definitely do weights. We do all of those things that I mentioned, all the anthropometric measures. You don't just do one. I don't think it would be fair for me to say there's just the mid-arm circumference that you take and nothing else. So we kind of take the whole conglomerate of all of those measurements and sit down together and talk about with the RD and say, okay, what's happening here? So not just the BMI or not just the weight. Did that answer your question? So the first thing you do is you ask for so the kid comes to us, and what do? The pediatricians are all freaking out. Oh, the kid's weight is down, and there's something going on with this kid. You need to see him. So the first thing is, what has been the weight trend? Not the 1-point weight. What's he done through the whole kind of past couple of years or longer? Talk about chewing and swallowing. How does the kid chew? Ask the parents. Does he chew well? And tongue movements, dietary adaptations. A lot of the kids, when they have these swallowing problems, will either tend to kind of, when they swallow, they put their heads back and stuff. Those are just natural reflexes in the body which tells them that if you do that, it's easier to swallow. Or they'll flex their head or turn their head. So those are some of the things that you ask for. And then how long does it take for them to feed? Does it take them an hour to feed, have a mealtime? So those are some of the questions you ask. And then also about coughing and choking. Does the kid vomit? Does he get recurrent chest infections? Again, recurrent chest infections could mean worsening the clearance, something wrong there, or aspiration, or both. Wet-sounding cough or gurgly breathing. That's another key thing we ask for, and that sometimes indicates that the kid is at risk for aspiration. So when secretions are not cleared because the pharynx isn't strong enough to push the bolus into the esophagus, secretions tend to collect in the back of your pharynx, and then when you breathe through it, you get that wet, gurgly sound of breathing. So I hope that sounded right. So So then you ask about meal times. Are they stressful? Are they enjoyable? Or, and parents will say it takes an hour and we can't handle this. We have other stuff to do and it just takes forever to feed the kid. And then, of course, you have to actually assess the kid. You get all that history, make your opinion, and then you actually see the child and you see what he does. You assess the anatomy, look at the lips, tongue, jaw, palate structures, assess the function, abnormal mouth architecture, look for that open bite, look with the anterior loss when they eat, a lot of it just falls out of the mouth, malocclusion of teeth. And observe the child eating a meal and record the meal time. So this is kind of what our speech and language pathologists do for us. And then the video swallow study, I think somebody alluded to this earlier, and there was questions as to when you do them. So first of all, what is the video fluoroscopic study of swallow? It's also called a modified barium swallow. Different institutions call it differently. So what is it? It's a radiological or X-ray study of contrasts passing from the mouth to the esophagus. It allows oral manipulation and swallowing efficiency with food of various consistencies. So you first give liquids, see how the child does with the liquids, then you give them semi-solids, then you give them solids, and you see how the chewing movements are, how the child is moving, how's the tongue movement with the bolus, is he able to squeeze that pharynx hard enough to push the bolus, or is there residual stuff staying behind in the pharynx after he's swallowed? So you look at the oral phase, which I said is the first phase, which gives information about chewing, the ability to manipulate food into a bolus and transfer it to the oropharynx to initiate the swallowing process. And then the pharyngeal phase shows the efficiency of the bolus transfer through the pharynx and also any penetration of the laryngeal inlet, because you can see that contrast. If it's kind of wanting to go into the airway and not the esophagus, that's a warning sign. That's called penetration. And sometimes you can actually see the contrast going straight down the airway, and that's frank aspiration. So what are the abnormal stuff that you could see? You see deficient buccal closure, where the mouth is not tightly closed and there's anterior loss. You can drool. The child has abnormal tongue and jaw movements, leading to difficulties with bolus formation. And they just keep the food and pocket it in their mouth. They don't swallow. They just keep it in their mouth. And they keep making these chewing kind of movements when they're really not chewing it. They're just pocketing it. Because the body's telling them you cannot swallow. If you swallow, you're going to aspirate. So that's kind of the reflex mechanism underlying that. There's delayed onset of swallowing. So again, holding it there because they know if they swallow, they may aspirate. Nasopharyngeal penetration, reduced pharyngeal peristalsis, or reduced contractions at the back of the throat. And then failure of pharyngeal emptying. This is the residue that I was talking about. After the kid has swallowed, there's still persistent food bolus in the back of the throat. Means he hasn't cleared completely. And what does that mean? When he starts to breathe, that might just plop right into the airway. Contrast penetrating the laryngeal inlet, and then the frank aspiration with the contrast falling below the vocal cords into the trachea. Another important thing is you need to make sure when that happens, if the kid is aspirating, is he coughing or not? A lot of our kids, after a while, won't cough. Cough is a natural reflex, right? When you aspirate, your body tries to get it out of your system, so you cough and you throw that thing right back out. But they don't have that ability to cough because of their muscles, their chest muscles, their laryngeal muscles. It's not strong enough to generate enough pressure to push it back. So quietly it just keeps going into their lungs slowly over time and getting worse. That's why that's called silent aspiration. When you hear the word silent aspiration, it's a little bit scary. Okay, so, and why is it silent? It's because the deficiency of those muscles in their inability to kind of throw the thing back out. So aspiration, when you look at aspiration, it can occur at the time of, before the time of swallowing. So here the kid has, the food is still in the mouth. You see the blue thing? It's still in the mouth, and it's already trickled and aspirated into his lungs, even before the swallow occurred. This is as the child is trying to swallow, it goes both in the esophagus and into the airways. And this is after. The kid swallowed fine, but the aspirate is going into the airway and the esophagus. So it can occur at any time. This is the worst, obviously. So this is a picture of a video fluoroscopic study. Obviously, it's a video, and I didn't get a chance to download the whole video. But here what you're seeing is, this is the airway that's in this is the contrast, the black, and it's going into the esophagus. But as you can see, There's some black in the airway as well, and this is the little amount that the patient has aspirated into his airway. So when you have dysphagia, which means difficulty swallowing, you can aspirate, and then you have poor cough reflex where you're not able to cough and it's a silent aspiration, you get pneumonia. A word to be said about oral care. If you don't have good oral care, if you have gum disease, you have gingivitis, and you have infection there, that can contaminate your saliva and your secretions, which can go into your lungs and cause a bad bacterial pneumonia. You can also reflux secretions from your stomach, and then that can go into your lungs as well. So that's called acid reflux with pneumonia. So you can have pneumonia from aspiration from above or from reflux from below. So now you're told your child needs to gain weight. All right, so what do? Well, we have the formulas. Formulae can be taken orally. There are several formulas out there that have different flavors, strawberry, vanilla, etc., that can be taken orally. So if they can do that, thickened, they will take that by mouth and hopefully gain weight. Typically, volume per volume, formula have more calories than does, say, any other thing that you eat, other than, of course, if you make a thick smoothie with fat and stuff like that. But typically, you get more calories that way. Now, a lot of the formulas can also obviously be given through the G or the GJ tube, and we'll talk about that later. The formula could be classified as cow's milk protein-based, soy-based, with no cow's milk protein for kids that are allergic to cow's milk protein, lactose-free for those that are lactose intolerant. If you're allergic, you could do either elemental formula or amino acid-based formula. There are some organic formulas available. Then you can thicken them using different kinds of thickening agents that are commercially available. Or you can do pureed diet through the G-tube, not the GJ, but the G-tube. And that you can make at home under the supervision of a dietitian. She'll tell you what to put in that pureed. You use a blender at home, put all the stuff, blenderize it, and give it through the G-tube as a bolus. And then there's commercially available pureed diets as well. So the formula, there's the regular supplement. Regular formula is like 1 calorie per 1 ml. That's the regular formula. Then there are concentrated formula, which are 1.5 to up to 2 calories per ml. But remember, you have to be careful when you're giving concentrated formula because you need to determine free fluid intake and need for supplementation because a lot of these kids are not drinking enough. Just by giving them extra calories, yes, you're giving them the extra calories they need, but you're not giving them the very important free fluid that they need with it. So be careful about that, and the dietitians can calculate how much free fluid that your child needs. So, and oftentimes I tell you, a lot of our kids with CMD are not drinking enough fluid. Also, there are high protein containing formulas available because, it's the muscle degenerating or getting dystrophic, you need more proteins to prevent that or reduce that or whatever. But remember, when you have a high protein load, it can affect your kidneys. If your kidneys take a hit, you don't want an additional problem there. So you have to be careful about not giving excessive proteins either. If the child is exclusively formula fed, you don't really need to supplement vitamins. But if you're not on a formula, which are pretty complete in their vitamin contents, you can look at the ingredients, then you do need a supplement. So now you're told your child is having inadequate weight gain, despite the mother saying, I keep giving him all the things you tell her, but the kid's weight is going nowhere. So what are the reasons? So even the supplemental calories may be inadequate for the child, or there may be some absorption issues from the gut which we haven't diagnosed or checked or looked for. There could be some vomiting and or diarrhea where they could be losing those calories, usually not seen in our CMD kids, at least that I'm aware of. Let me know if you do. Increased calorie needs, and that's probably one of the major ones in a lot of our kids with CMD, because any chronic medical condition such as congenital heart disease or chronic pulmonary disease, which I'm sure Dr. Hemant can tell you, they have, and that increases their need for more calories, but you're not giving them enough. So therefore, it's a relative deficiency of calories there. So what do you do for management? So there's 3 categories. So you put your child into one of those categories. Failure to thrive or poor weight gain with a normal swallow. First thing you do is you try to, I lost my pointer. The first thing you do is supplemental high-calorie formula and beverages like we talked about, increase calories in their solids by adding up butter and oil. And you can only do this if your swallow is normal. Do not be adding oil and butter to your child's solids if there is even the risk of aspiration. Because if you aspirate fat, oil, greasy stuff, you get lipoid pneumonia, which is extremely dangerous and potentially fatal. So now, if the child has failure to thrive and has an abnormal swallow but no aspiration detected, then you can do the speech and language pathologists will talk about seating and positioning their heads and adaptive skills and devices to assist with feeding, viscosity, thickness modification, pacing, meaning don't swallow too fast, go slow, oral motor therapy with a therapist. And then if it's a third category where there is aspiration or very high risk for aspiration on a video fluoroscopic study, then you do all of the stuff in second, in number 2, and then you only allow safe foods by mouth. So that could be just solids, certain textures. And then that's the point where, depending on other things, consider a G or GJ tube. And I put both of those together because it all depends, and we'll talk about what are the things you think about before you come to make that decision. Timing. When do you, that's kind of a question always asked. When should my child get a G-tube? It's a difficult question to answer, and like I said earlier, you have to put a lot of things into consideration before you come to that decision. So if the child is having persistent weight loss, despite all your efforts to increase oral calories and nutrition, you've done your best and the kid's not going anywhere. His weight's still going down. Persistent dehydration, calories may be fine, but the child's getting dehydrated because they're not drinking enough fluid. Aspiration, recurrent pneumonias, worsening respiratory status, worsening muscle strength, prolonged meal times, child-family readiness, we have to look into that, and can the child tolerate anesthesia? Now, if you think, oh, well, I want to get a G-tube because we've checked on all the rest of the stuff, the anesthesiologist said, heck no, we can't do this because his muscle and his respiratory status is so poor, he cannot withstand anesthesia because it has to be done under general anesthesia. So that's out. So you have to kind of make that decision, taking into consideration all of that. So I personally, and I'm just saying it, this is just my personal belief, I like to put G-tubes earlier, right at the beginning of any abnormal swallows that I start seeing, or the child's getting more pneumonias, the wasting has started, and the pulmonologist is saying, you need to get the nutrition better, and parents are saying, we're trying our best to get all the nutrition you're telling us, but it's really not getting it. So all of those you consider and then say, yes, let's go ahead and do a G-tube. So improving your nutrition and fluid status. Why do we keep saying, improve nutrition, get the fluid status under control? And that's because if you have good nutrition, it delays the muscle atrophy. That's been shown. It improves, therefore, your mobility. It slows the worsening of your respiratory status because your muscle is not atrophying as quickly, so the strength is preserved, so your lung function is preserved. It delays the kyphoscoliosis because if your muscle strength is weak, your kyphosis and scoliosis tend to get worse. It induces puberty. A lot of times we've seen a lot of our kids, because they're so poorly nourished, that they don't go into puberty until 16, 17, 18, 19 sometimes. So once the nutrition status gets better, they go into puberty, and that's a huge psychosocial thing for them. It reduces osteoporosis. Better nutrition, you're getting enough vitamins, you're getting enough calcium, you're getting enough, the rest of the nutrition. So it reduces the osteoporosis as well. Improves cognition and mood. If your nutrition is better, you're hydrated and everything is good, you feel better, your mood's better, you're not depressed. Children that have undernutrition are depressed. And you really don't want that in addition to everything else that's happening. And of course, because of all of that, it improves quality of life. So the need to increase calories, like I said, you could do, I think we've already gone over this. Let me just skip it. So just a word about vitamin D and bone health. The lack of weight bearing is a major contributor of bone loss. So if you don't bear weight, you tend to lose bone mass. okay? And that's been shown in all cerebral palsy kids that don't walk and non-ambulatory kids. And what is osteoporosis? It's a systemic skeletal disease. Systemic meaning it's not just in one single bone, it's in all bones. It's characterized by reduced bone mass or bone mineral density, referred to as BMD, and structural deterioration of bone tissue leading to thin and porous bones with a subsequent increased risk for fractures. And what's scary is the next point. There's a strong inverse, meaning opposite, association between bone mass density and fracture risk. There's a 2 to 3-fold increased risk of fractures for just one standard deviation decrease in your bone marrow density. That's pretty scary. In addition, a lot of our kids are on chronic steroids and other medications that can potentiate that reduction in bone mass density, so puts them at higher risk for fractures. So there was this very interesting study and looking at BMD and vitamin D levels, but this was in non-ambulatory children with cerebral palsy. And they found that the main predictor of low BMD Z-scores was the inability to walk. That was the one thing that affected it majorly. And then the vitamin D status really did not correlate with the BMD Z-score. That was a very interesting finding there because we would always think, well, if the vitamin D is low, that's why you get osteoporosis. But there really wasn't any relationship between the blood levels of vitamin D and the Z-scores on the bone mass density, bone mineral density. There was another study looking at effective interventions to improve low bone mineral density in cerebral palsy. Again, I'm using cerebral palsy because there's really no data for us. So they said for the use of bisphosphonates, you guys know what bisphosphonates is, it improves bone density. It's a medication. The efficacy was probable. It probably helps, nothing categorical. Vitamin D and calcium supplementation possibly helps. Weight-bearing activities, insufficient evidence to say one way or the other. So it kind of doesn't go along with the prior study that said that. So just to kind of say, there's a lot of data out there that we are extrapolating from other conditions, which may not be true for our CMD, but that's kind of the more similar kind of group that we're trying to get the data from and using it for our CMD. But again, it's consensus driven. There is no consensus between any of the gastroenterologists and nutritionists if you talk to them. And that's one of the things I would strongly recommend is for coming out with a care consideration for congenital muscular dystrophies, where all the experts sit down, and even though we don't have a lot of data, but then from their experience that have seen a lot of kids say this is what we should be doing and this is what we should, and then that other guys across the country can do. We did a similar thing for DMD and as part of the GI group. And the last, there may be some role for testosterone in improving bone mineral density in adolescent boys. Now, refeeding syndrome. If your child is really, really malnourished and you get a G-tube and the doctors go crazy about, starting calories and start throwing all these calories at the child, that's when you have this problem, which can be potentially fatal. So what is refeeding syndrome? It's a metabolic disturbance that occurs as a result of reinstitution of nutrition to patients who are starved or severely malnourished. There's a potentially fatal shift of fluids and electrolytes that result from hormonal and metabolic changes that occur in your body as you're getting this barrage of nutrition suddenly when you're baseline malnourished. And what it does is there's a significant drop in serum potassium, magnesium, and phosphorus that leads to neuropathy, vomiting, ataxia, ocular cranial nerve palsies, tachycardia, fluid overload, and sometimes death. And to avoid this refeeding syndrome, once they get a G-tube, what we always do is to increase the calories gradually. Don't just start flooding them with what you think they need. We start with a 1/3 required, then we go to 2/3 after a few days, and then we go to the entire amount that we need to give them. And then, of course, you have to closely monitor for blood work for 2 to 3 days after you start increasing the calories to look for the potassium, magnesium, and phosphorus drop. Now, Moving gears a little bit, what are the advantages of G and G tube feeds? It's pretty intuitive. It improves nutrition and hydration. Meal times are much shorter. They are less stressful. It lessens the risk for aspiration, and there's better quality of life. So these are some of the G tubes. Most commonly, we do endoscopic placement, and it's called PEG, or percutaneous endoscopic placement of tube. On the left side, you see the camera, the endoscope going down into the stomach. We make a little nick in the anterior abdominal wall, and then that's what the G tube looks like. So on the left, the brown part is the interior of the stomach, and that's your body wall. The brown right there is the stomach wall, and then the anterior body wall. So you see the tube going through both the walls into the stomach. This is what a G tube looks like most commonly. There are different kinds of G tubes. I'm just showing you one, but I'm sure the people that are in the room that have this, they know what the things that you need to know is what kind of G tube your child has. Is it an AMT? Is it a Mickey button? What is it? And what are the sizes? Is it what is the French, which is the diameter in red, the diameter of the tube? What is the length of your G tube? So 2 centimeters, 2.5 centimeters, whatever. So when you go to the emergency room, if your tube is fallen off, you tell them, hey, my child has an AMT 14 French 2.5 centimeter balloon. This is a GJ tube where you see there is a part that opens into the stomach, the blue part, and then within that there's another longer tube that goes past the stomach into the intestines, and you're feeding into the intestines. When do you do that? We sometimes do that when a child has gastroparesis, meaning the stomach is affected, it's not contracting, and the food's just sitting there and causing him to vomit and sometimes aspirate. So you feed past the stomach, also called transpyloric feedings. So you're feeding beyond the stomach into the jejunum or the small intestine, so the formula doesn't come back into the stomach because there's a sphincter muscle that's shut between the stomach and the intestines. It prevents that from coming back into the stomach. The beauty of this is that you have the gastrostomy tube that you can vent and let the stomach and air and everything out of the stomach. This is what the GJ tube looks like. So on the left you have a button, a GJ tube button, and on the right is a GJ tube. The difference being the button, after you take out the attachment for feeding, is just a little button there, but the GJ tube has this long tube that always sticks out of the belly. There's different reasons why we use these. So that's a skin level device, and that's not. In the GJ tube, you have those 3 ports. One is the gastric port going into the stomach. You have the jejunal port where you feed, and then of course that's the balloon on the other. This is what it looks like endoscopically. So in the stomach, you see the balloon coming into the stomach, and then that long tube that's going past out of the stomach and into the intestine. Remember, when you have a GJ tube as opposed to a G tube, you can only give continuous feeds using a pump. So you need to have a pump, and you have to continuously feed. You cannot give a bolus like you do for G tube. Just take a syringe and bolus through the G tube. You cannot do that with a GJ. You have to have continuous, and you need a pump. If the GJ tube gets displaced, meaning sometimes it kind of comes back into the stomach, then you're essentially feeding into the stomach. So I'm almost done. So you have to go to a hospital, to a radiologist to actually place the GJ tube. You cannot do it at home. The G tube you can, but not a GJ tube. And then, like I said, the G port could be used to vent the stomach or give medications. These are some of the problems you can get with the tube, G or GJ: some leakage, skin irritation, granulation tissue, gastric mucosal prolapse, clogged tube, some gagging and retching after a Nissen Fundoplication. I think I'm going to stop right here and take questions, if there are any. Yes, sir.
So it's really amazing to see the importance of nutrition and how it can help to have the quality of life and to extend the negative effects of
Poor nutrition.
Here you go.
Yeah. So 2 questions related to your speech. It's
calcium and vitamin D. As we have daily needs of vitamins and nutrients, what is the expected duration of this supplement? Is it until you are a teenager, or is it something you can do every 2 months and then stop 1 month and then 2 months? So what is the frequency for this?
Of the multivitamins?
Yes, kind of calcium and vitamin D.
So it all depends. I mean, even though the data showed otherwise, a lot of the people are still measuring calcium and vitamin D levels and using that to supplement vitamin D. We typically put them, and a lot of these kids have to be, if you look at vitamin D deficiency, it's very, very, very common even in the normal population. And on top of that, if you have dystrophy, it's even more, makes the problem even more acute. So you really want your vitamin D levels, depending on what the lab you're using, but above 30 is what we aim for. And if it's dropping below 30, then we try to keep the supplement on however long it takes. Vitamin D, a lot of our kids are on it long term. Calcium is a different matter. You have to be careful with calcium, because if you give additional calcium in your stomach, it can cause a lot of other problems, because when you're giving other medications with the calcium, it can bind some of those medications and reduce their efficacy of the other medications. And you can get some stones and stuff like that, so you have to be careful about calcium. We don't give calcium supplement as much as we do vitamin D. Vitamin D for sure, and a lot of them are long-term.
Excellent. And the second question is regarding collagenum. There are some kind of marine collagenum, like that you can dilute with the water and drink it. Is this something that could help because of the lack of production of the collagenum 6?
I doubt, but I honestly have no experience using that. But I seriously, if you look at the pathology of what's happening in collagen disorders, by giving extra collagen, it's not going to really get to where it needs to be or help you there, I don't think. But again, I might be wrong. I would be the wrong person to ask. So I don't know. Yes, ma'am.
Hi. I have a 4-year-old son with collagen 6. He is 4 years old, 30 pounds. Even though he's not losing weight, he is not gaining it. It seems he's been the same weight for the past year or so. What is the calorie intake for his age, considering his condition? I do believe he is adequately fed with snacks and proper nutrition. I am confident in that 110%. But I'm not seeing any positive effect on his weight. A G-tube was kind of mentioned to us, if he considers to do so. So I'm kind of hoping for your input as far as calorie-wise. Pediasures were recommended. He is not taking those. Of course, we do the butter, we do the peanut butter, we do chocolate on top of the peanut butter, you know, anything that you can possibly think of that normal people get fed on, you know. So what is your
So like I said, putting a G-tube is not an easy question. There's a lot of things you have to, not just the weight. So if there's potential for him, if his oral motor skills are good and he has no problem swallowing, well, we say yes, but a lot of times there is some subclinical thing going on. And I cannot tell you how often, not necessarily in CMD kids, but in other kids that have feeding issues, have, you know, but those are especially kids that take long to eat. He doesn't take long to eat.
He does take long to eat. He's never aspirated, ever, that I know of. He's never had pneumonias, so his lung health is still good. I think it was mentioned to us more so to be proactive than anything. Like you mentioned earlier, you'd rather put it earlier than later. But aspiration is not the issue. It's strictly just the weight and lung as a result.
So you say aspiration is not an issue. Are we sure he has no subclinical aspiration? Because we all aspirate. You aspirate, I aspirate,
well,
little bits, we all aspirate.
As a result, you know,
right.
Or has not been brought to our attention. Otherwise, he is fairly healthy.
So just the late swallowing, like taking time to eat
He is
could
taking
be
quite a bit
and
of time,
could
yes.
yeah, it could be an indication that something might be going wrong. So I would definitely get a swallow study before you decide on anything.
Swallow study. Okay.
Swallow study for
That helps
sure,
me. Okay.
because that gives us a lot of information. Is it just purely a matter of weakness in the mouth and that kind of weakness in the pharyngeal muscles, or is there more? Can you see the penetration? Can you see not actual aspiration? And you might be surprised. There may be aspiration, and you don't know that he's having aspiration. And the other thing is, you get pneumonia only if you aspirate a large amount.
Okay.
So if you aspirate little bit,
Okay.
you don't get the pneumonia, but it's enough to cause more inflammation and worsen lung disease. For your kid, I would definitely get a video swallow study.
Okay.
And that's not the only thing. Again,
Right.
there's other things. So if there's muscle waste, more wasting, and the lung function is deteriorating, so that's another indication. Why is this lung function deterioration? Is it because of nutrition, or is it because of aspiration? Silent aspiration, small, not enough to cause a pneumonia, but enough to worsen the lung function. Is that contributing? So we need to get a little bit more information.
Okay. I appreciate it. Thank you.
Yes, ma'am.
Hi, so the placement of the G2 is determined by your scope that goes down. It's not my question.
Okay.
So with the movement, because of her scoliosis and then her surgeries with the grow rods and then her future fusion, should we be concerned about her G-tube not being in the right place? Will she need a future surgery as she grows, that her G-tube should be replaced, more? I just never asked those questions.
Sure, and those are excellent questions. How old is she?
She's 14.
So she's probably not going to grow much now. The ones where we sometimes have to change the gastrostomy site is, first of all, it's very rare, and it's if they've placed it too high below the ribs, and when they get the scoliosis, it kind of gets underneath the ribs. So you have to be careful. Most cases that I've seen, we haven't had to change the site of the G2, because what we do is we stay away from the midline and weld at least 2 finger breadth down below the rib cage. So there's enough kind of space there. And then on the inside, what's more important is in the inside of the stomach, when you have the scope in there, you want to be not too close to the exit of the stomach. You need to be a little bit away from it. So towards the lower body of the stomach, main body of the stomach. So I've honestly, in all my years, 20 plus years, I've never really heard that they had to change it because of scoliosis but I will tell you, our orthopedic surgeons, before they put their kids on for scoliosis surgery, there's 2 things they ask us. 1, work on their nutrition. Yeah, they just kind of order, wonderful surgeons. You have to improve the child's nutrition. Yes, sir. And 2, give us a recommendation of what we should do with the constipation, which we didn't talk about today, as to clean out prior to the surgery and stuff. So those are the 2 things that they send the kids to us for, the orthopedic surgeons to. Did that answer your question?
Yes, it did. Thank you.
Thank you. Yes, ma'am.
I have a 3.5-year-old son with LCD. He had a G-tube placed when he was around 2 years old, and we struggled with vomiting for the longest time, so we switched it to a GJ in January. Starting March 6th, he's been throwing up every day, and we can't figure out why. We've switched formulas. We have gone back to the G because with the J, he was throwing up at the same time every morning. We've had an endoscopy done. We've tried different medications for motility, medications for reflux, Zofran. Nothing's helped.
So the first question I ask is the gastric emptying normal?
As far as we know, yes. He still has wet diapers. His bowel movements seem relatively normal.
So there's a test we do for stomach emptying. It's called the gastric emptying scan.
Okay.
Has he had that test?
He hasn't.
Because it gives you
had
an objective kind of number of how quickly the stomach empties food.
No, he hasn't had that test. We did try erythromycin to speed that up, and it didn't seem to make a difference.
Okay. Can I take a minute real quick? So when you look at the stomach, let's talk about this. The stomach, The stomach is shaped, there's a dome of the stomach, right? That's called the fundus of the stomach. And then there's the body of the stomach, and then there's the antrum, which is the lower part before it goes into the intestine. So those are the three major parts. Pylorus is the muscle that's closed and opens up when the antrum squeezes stuff past. So there could be problem with the fundus, because the fundus is important in accommodation. In other words, when you eat food, the fundus of the stomach, the top part, actually relaxes and becomes big. Sometimes you wonder how you can put a whole big, huge plate of food. That's because of the fundus relaxing and accommodating the food. The function of the body of the stomach, which is the central part of the stomach, is to squeeze, mix the food, and then push it down towards the antrum, which is the lower part. The antrum part, the third part, acts like a pump, and it squeezes hard and squirts the food out of the stomach through the pylorus into the intestine. So you may have a problem with any of those or more that can lead to this problem of him vomiting. I'm assuming they've looked for other causes of vomiting, like kidneys. Vomiting could be from other reasons too. Yeah. Kidney stones and the rest of the stuff, brain sometimes, increased intracranial pressure and stuff. I'm assuming they've taken a look at that. So you need to know if there's any problem with the gastric emptying, and if there is, it doesn't empty well, then that's the reason he probably got the GJ tube. Right. Now, rarely, some kids also have what we call pseudo-obstruction. It's like pseudo means fake, right? The intestines act like they're obstructed. They just don't squeeze and push food. They just kind of sit there, and the food's trying to go through it, and there's problem with that, and then obviously it goes back into the stomach and you puke. So is the intestinal motility normal or not? So I'm not aware of any literature that says that children that have that condition of CMD have more incidence of intestinal dysmotility. Again, going back to the question of there's really not been a lot of research done. Nobody's really looked at whether the muscles are affected, the gut smooth muscles affected in children with CMD. So that could potentially be an issue too. So there's a test called antroduodenal manometry that we can do. We essentially place a tube that measures pressures. It's got sensors built in the tube. So you put the tube through the GJ site into the intestines, and you measure pressures and see if it's normal or not.
Okay, so with the J, and he was throwing up like mucousy type stuff every morning, but no formula. So could that all be related to that as well?
So sometimes kids that have a GJ tube and they're small and they have a bigger J part, the tube going into the intestine, sometimes obstructs that pylorus muscle. That's the outlet from the stomach into the intestine, because the tube is big and it's blocking the pylorus. So whatever secretions, normal secretions the stomach is producing, it can't go out into the intestine. It just sits in the stomach. You feel nauseous, and he just throws up. And we typically also recommend venting the G tube before feeds, and several times a day try to move the child to get the air bubble and secretions and everything out before you actually feed, and that can sometimes prevent.
We do continuously vent it at night when we're running the J. Are you saying those secretions should maybe come out of the G, and maybe that would solve the problem?
If it's blocked by the JJ tube.
J. Okay.
So you can certainly try that. It's an easy enough thing to do. So instead of venting it just at night when you're feeding through the J and venting the G, vent the G during the day too.
Okay.
See if that improves. When does he typically throw up?
Well, when he was on the J, it was every morning between like 5:30 and 7 a.m.
Uh-huh.
And when we have him on the G now, because he's on a BiPAP, so we couldn't risk him throwing up at night, it's hard to predict when it will happen with the
So
G.
there could be a motility issue, either of the stomach or the intestines or both. So that's something we need to look at. Okay. He's not constipated, is he?
No.
And the reason I say that is because constipation is very common in CMD kids, and constipation can actually, if your rectum and your lower colon is full of stool, it actually slows the stomach. It's called intestinal reflexes. So the lower bowels talk to the upper bowels and say, hey, wait a minute, we are full right now, slow down. So that kind of makes you more gaggy and kind of stuff, and also gives you fill and reduces your respiratory movement, the diaphragm movement and stuff. So. That's what Dr. David meant by FOS, if you were wondering what FOS was. Huh? Oh yeah, I didn't get a chance to talk about constipation, but yes, some other time. It's a huge problem.
Having a stool
Absolutely. They all say Miralax, but honestly, my recommendation is, I honestly recommend more a stimulant laxative, which is, I know this is off the topic and we're going to the other end now, but a stimulant laxative like Senna or Dulcolax. Senna is an herbal preparation. I prefer Senna.
I used to get at Whole Foods Buddy Bear. It was like a little bear. When he
With
was
the-
little, it
Was it Senna?
little bear. I don't know what
Herb.
it was from something herb for kid children.
Right.
Bear laxatives.
Yeah.
That worked when he was little.
Right.
Had to move up.
Right, because laxative could be just a stool softener or a stimulant. Stimulant is what pushes, and CMD kids really need a stimulant. Miralax itself just makes the stool soft. That's not.
So stimulant tells the brain.
No, stimulant actually, the Senna stimulates contractions in the colon and pushes it out. Yeah. Sorry? Senna, S-E-N-N-A, Senna. There's different preparations. There's a liquid preparation. There is a chewable tablet that you can chew, chocolate flavored. There's also pills. There are extra strength pills, 25 milligrams per pill, that you can take. So for older kids, you probably need those extra strength pills. Was that your question too? All right. Anything else? Thank you so much for waiting, guys. Thank you.